Thank you. Just a few comments while we're getting set up. Once again, I really want to thank the organization for the privilege of the podium. Again, Professor Mandel for really giving me a wonderful trip here, and the opportunity to speak is incredible. I must say, though, I'm a little bit disappointed. Why must I speak after Shailesh? It's like a tough act to follow. He's one of the best speakers, and so that's about the only disappointing thing about this, but everything else is great. The whole meeting has been wonderful, including the award presentations this morning I thought were great. So before everybody runs out of the room, as we're all surgeons here, and you see this title, Precision Med, Use of Liquid Biopsy to Predict Response in Cancer, and I know what everybody's thinking, now would be a good time to take a bathroom break or maybe to check my emails, because what does this mean to surgeons? But one of my goals in the beginning, and it's not to get too deep into the science, is to understand what this science means. And I want to convince everyone here as surgeons, because I was convinced that this topic, not necessarily the work that I'm doing, but this topic is one of the most important topics for surgeons in the future. And furthermore, that surgeons should lead this research and do lead this research, because it's important just as much as all of the technical things, which are absolutely important, just as much important to the future of our field. Now, you say measuring liquid biopsy to predict response, so what exactly is it that we're going to measure? So I'm going to talk a little bit about tumor biology as it applies to localized resectable cancer, the ones that we mainly deal with, and then discuss, without going too far into the science, the power of liquid biopsy. So in predicting response, what do we want to know? What response do we want to predict? Well, there's many, many different things, and they all apply to surgery, and I'm going to focus on one today. We can predict response to neoadjuvant. We can predict need and response to adjuvant therapy. We can predict overall survival. All of these are important. But what I would like to focus on today is predicting the response to surgery. So in other words, what is the impact of an oncologic resection? Can we predict the impact? So in other words, who will benefit from surgical resection? And if you think about this and why this is important, you know, the art of an experienced surgeon is you look at a patient, you sort of look at the films, and we're really good at selecting people who will benefit, but it's not necessarily objective in how we do it. And so should this not be the most important question that we ask ourselves? Is this patient resectable, and how do we measure that? Our goal as a surgeon is not simply removing the tumor. Of course, we are focused on that, and that solely falls on our shoulders in the multidisciplinary team, is to doing a safe and effective resection. But if you think about it, really what our goal is ultimately is to cure, and that's what we want to predict. So if we ask ourselves the question, what is resectable? And I do this too. We're very much focused on anatomy, and that it's very practical. We need to know the anatomy. We focus on performance status. And then this thing I put in quotes is, what exactly is tumor biology? And I want to discuss biological versus anatomic resectability. And this is a very simplistic example of this, of how, you know, the extremes of this. This is a patient with a preoperative CT scan. I see Shailesh right now is getting his phone and calling the operating room to post for a lap Whipple. This is about a robotic or lap or anything. It'll be done in 2 hours. This is about as simple as it gets. It's a healthy patient, no vessel contact, low CA19-9, a resectable tumor, and, you know, standard of care is to go to surgery. You can argue whether you go neoadjuvant or not. Probably doesn't make a difference, and probably didn't make a difference in this outcome. Now, this doesn't happen often, but it happens, and ultimately maybe happens on a little bit of a longer time scale. 3-month post-op CT scan, metastatic lesions in the lung, in the liver, and carcinomatosis. Now, pancreas cancer is aggressive, but this is a little bit more aggressive than most. I would say that this tumor, well, of course they didn't benefit from surgery. I would say that this tumor was anatomically resectable, but biologically unresectable. Had we known this and been able to predict this, it doesn't mean that we would not have offered surgery, but maybe different form of neoadjuvant, maybe focus more on systemic control. Now, here's a little bit of the other extreme. So this is a tumor that basically wraps around every blood vessel. In the NCCN staging guidelines, this is stage 3, locally advanced, and we don't call it unresectable anymore because, as was demonstrated here at this meeting, many people are resecting these tumors now, but still sort of considered outside of the standard of care. So this tumor is anatomically unresectable, although with the skills of many in this room, it could be removed. You can see involvement of the portal vein, the SMA, you can see involvement of the celiac trunk, so triple vessel disease. This patient, who was anatomically unresectable, got a resection, has no evidence of disease at 4 years. So I would say that that patient benefited more from this big operation than the patient did from the small operation, and they were biologically resectable. So PDAC tumor biology, as I want to go over, what does that mean? I mean, it means a lot of different things, and we can get into the molecular aspects, but this is a simple but profound surgeon perspective, and we don't need these data to talk to this group of experienced surgeons, but this is something that we looked at and published years ago now. It was 500 patients, standard, underwent a standard Whipple operation, nothing exciting about it, but we kept very detailed records, and 80% of them recurred, not a surprise to anyone here, and also not a surprise, but it gives us in numbers, in actual numbers, what exactly happens here. In the 80% that recurred, the vast majority of recurrences were systemic. And beyond the scope of this lecture is I would argue that even some of the systemic, the localized recurrences are systemic too. So what does this mean is clinically localized pancreatic cancer is not biologically localized. It's a systemic disease. We have a solid tumor and a liquid tumor, or a distant tumor to deal with, and the impact of what we do as a surgeon is only as good as systemic control. Now, can we do anything about systemic control? This is an antiquated study, but I think it illustrates the point. We couldn't do this study anymore. This is the CONCO-1 study, a 10-year follow-up. Patients were simply randomized to surgery alone or surgery plus adjuvant with single-agent gemcitabine. I'm not arguing for gemcitabine, but if you look at this, 6% or 6 out of 100 of the patients were cured with surgery alone. Now, could we identify those patients and say, hey, you don't need any chemotherapy? And we say, well, gemcitabine, that's a pretty weak. But you know what? For 8 patients, it was a miracle drug because it cured them in addition with surgical resection. Now, as we get better and better chemotherapy, we cure more of these. But what it demonstrates is that the impact of systemic control elevates the impact of the operation. Because of gemcitabine, 14 out of 100 over 6 out of 100 benefited from the impact of surgery. So I would say this is why we should not leave the room, because I think systemic disease is the surgeon's worst enemy when it comes to our mission to cure. Now, we have a lot of enemies, bleeding and all of those things, so believe me, I understand that. But in terms of our goal to cure a patient, and Sun Tzu, Art of War, says, know your enemy. So we need to measure and understand systemic disease. Which finally brings me to my point is why we should be interested in liquid biopsies as a surgeon. This is a window into this systemic disease. Many things are secreted by the tumor and micrometastatic disease into the circulatory system. We could go on and lecture. I'm just going to focus on circulating cell-free DNA and circulating tumor cells, but there's extracellular vesicles, there's proteins that are emitted. And just for the sake of the time, we're just going to focus on 2. Now, what exactly is happening here? Well, a tumor grows from a pre-tumor to an invasive cancer. What does invasive mean? It can break the basement membrane. It can become systemic. That's why any cancer is lethal. And to the extreme in pancreatic cancer, it gains access to the circulatory system. It extravasates and forms these micrometastatic lesions, which the majority of the patients we operate on are metastatic. They're micrometastatic. And we say, oh, we have a recurrence. No, we really don't have a recurrence. We have residual disease that was not eliminated. Can we measure this and understand it? So for these reasons, we jump into this now. It's been maybe about 10 years ago, and we're able to identify circulating tumor cells, the cells that actually escape from the tumor based on genetics, their tumor origin. And we identified that these cells exist, and there's different subtypes. And that not all subtypes are important. It's the transitional type, the ones that are in transitional from epithelial to mesenchymal type. We also demonstrated that there was a second subset of stem cell-like, and these are important because they have the ability to remain for years in dormancy. They can recapitulate the tumor and repopulate a tumor, and so these are candidates for establishing metastatic sites. a whole other topic as we're trying to understand mechanism and basic science. But one of the interesting things that fell out of this is, can we predict things with this? So we performed it back in 2016, the cluster study. It was a prospective, non-randomized longitudinal study in which we accrued 200 patients and took approximately 600 samples over 2 years. They were PDAC patients, and again, we reestablished that there was 2 circulating tumor cell types, and the one that really correlated with outcomes were the epithelial to transitional type. Now, again, we won't get into too many details on that, but the interesting question is, well, is there anything we can do about that? Is there any impact? Well, we demonstrated that neoadjuvant can impact transitional tumor cells, that surgical resection can reduce the epithelial cells. The other thing then that started to become interesting, and it wasn't our initial goal, is we can actually predict, based on the absence or presence and the makeup and ratio of these CT scales, very quickly predict before surgery. Now, we didn't change whether or not we operate them, but we could predict before surgery already. Look at the stratification of their outcome. So this is not ready for prime time yet, and the punchline here is not going to be that it's ready for prime time, but we are at the point where we can start asking the questions, can we actually really predict survival, biological resectability? It's promising. One of the other things in terms of a biomarker, this is the curve of all patients who had early recurrence, less than a year. You can see there was initial drop in their CTCs. CTCs preceded the imaging recurrence, and then they developed an imaging recurrence. But this was not a nonspecific effect. Interestingly, the long-term survivors actually never had an increase in their circulating tumor cells. The interesting thing is they didn't all go to 0. We know they still have residual disease, but and that's an area of further study. So what does this mean? That's the take-home point. It's like a lot of words, but what does this mean for us? Well, if you look at this one particular patient, we went to the operating room. This was the number of their circulating tumor cells. There was a drop in the number of their circulating tumor cells after neoadjuvant and after surgery. They then went to surgery, had a further drop after adjuvant. In the first postoperative check, there was no issues. By the second postoperative check, the patient was doing absolutely fine and looked well, and there was no evidence of disease. But we knew already, based on this, that, as we say in English, the shoe's gonna drop. We knew already. Now, we couldn't do anything about this, but it demonstrates the power of the predictability of these circulating tumor cells. You can also see when it came back with a vengeance. And so we're now focusing on this genetic drift of the epithelial type, the epithelial mesenchymal transitional type, and looking at them in both the preoperative and postoperative period, and are able to predict outcome. So in terms of a test toward biological resectability, we are now getting there, developing tests, not to say we shouldn't operate, but how do we sequence operation with neoadjuvant, with adjuvant, and in some cases, they really will not benefit from an operation. The other strength of liquid biopsy and circulating tumor cells, we get a CBC all of the time, complete blood count, to understand infection and all of these things. Circulating tumor cells are very similar in a way, in that they are not non-specific. They are the disease itself. We can actually isolate these cells. We can do genetic analysis. We can do expression profiling, and we can do drug sensitivity. So it's almost like a cancer CBC. We can get information, and the thing is for us as surgeons, the primary tumor is not an issue. It's sitting in a bucket in pathology. We don't care about the primary tumor. We care about what we leave behind, and now we have a way to measure what we leave behind. Now, just to mention on circulating tumor DNA, I work in both fields. It's not like one's stronger than the other. They're complementary. They just measure different things. And the only reason I bring this up is we found a similar thing in circulating tumor cells, that it correlated with recurrence, in circulating cell-free DNA. It was very similar in that the recurrence, molecular recurrence, precedes imaging recurrence. The point being is that this is ultimately where the field is heading. Circulating tumor cells give some information, and it's pretty powerful. And in the discussion, I'll explain why we're not quite ready for prime time. Circulating cell-free DNA gives some power, but it also has its limitations. When you start combining tests into composite tests, statistically to overcome the weaknesses of the other, the predictive capability becomes very strong. You know, we can actually now predict pretty well using composite tests, using an individual test. One of the reasons we're not ready for prime time is still a lot of work needs to be done in terms of prospectively validating these tools. But it is promising and it is important to surgeons. So in conclusion, clinically localized pancreatic cancer is a systemic disease. That is the tumor biology that's important for surgeons. Biomarkers to measure, evaluate, and predict biological behavior will be necessary to prove outcomes, and they are on the horizon, and this should be run, that field should be run by surgeons. Liquid biopsy can be a window into that systemic disease. That's what we carry for. It's a little counterintuitive that we're not so much worried about the primary tumor, we're worried about what we leave behind, because that's what our patient is going to live and die, and this is a window into that. And circulating cell-free DNA, circulating tumor cells, among others, like extracellular vesicles, show promise. Still, much work needs to be done until they're integrated into daily care. So, once again, I want to thank the Association for the privilege of the floor. It's quite an honor to be here. It's been great meeting and fun, and I really appreciate having the opportunity to speak to this group.
Can this liquid biopsy have a diagnostic role before surgery?
Yeah, so that's a great question. So we haven't focused much on that, but there has been cases, and it's not usual, where we intend to give neoadjuvant because it's stage 3 or the CA19-9 is elevated, where our endoscopists try to get an FNA. And for whatever reason, there's some patients that 2-3 times they cannot get a tissue diagnosis. Our medical oncologists will not give chemotherapy without a tissue diagnosis. We now have them to the point where they'll accept a positive circulating cell-free DNA or a positive CTC test. So it's the beginning of you know, can it be used for diagnosis? The more interesting question, and sensitivity is going to be an issue, can it be used for early detection? And now a lot of that work is being done by the Hopkins group now under Bert Vogelstein and others, where they're able to detect cell-free DNA in patients who have pre-malignant lesions, and hopefully in the next 5 to 10 years they'll be able to work out, you know, because you can pick up a KRAS mutation in a low-grade dysplasia, that doesn't need to come out. But hopefully they'll be able to work out the details of high-risk lesions, which needs to be. So I think that the strength really of early detection is even more so than diagnosis. It's a field separate than what I'm focused on, but I think it's absolutely important. The other thing that shows that I think that they'll get there is that recently the cis fluid analysis for molecular mutations, they now have high risk they can identify a high risk lesion based on the different mutations. They should be able to ultimately do that in circulating cell-free DNA, and you know, hopefully there'll be promise in early detection. It'll be worked out in high risk individuals before it moves into screening large populations. I'll probably be dead by then, but.
Good morning. Thanks for this wonderful presentation.
Yeah.
I'm aware of the impact that you had already shown on the basis of keratin and vimentin specificity for the CTCs in that seminal paper. I'm just wondering whether you would say something about the cornell work that is going on about the neutrophilic traps in the liver. But yeah. So what's your take on that?
Yeah.
And whether you do see something like induction immunotherapy like colon cancer sometime in the future, please?
Yeah. So they're great questions. I mean, the question was about neutrophil traps, which the neutrophils play an integral role in the capture of these cells within the pre-metastatic niche, and form that without the neutrophils, you would not be able to get progression or these formation of micrometastatic lesions. And I mean, that's it's a quite interesting thing, and it's something that, it's hard to work out in a human. It can be done in a mouse model, but what does that mean? Because the immune system is so big. But we are working not so much on the neutrophil traps, but on the mechanism of how these cells remain resistant and evade the immune system. Doug Fearon in a Nature paper several years ago demonstrated that in dormancy, they don't express MHC1. And these neutrophils then are sort of neutral and don't anything. So working out that mechanism is exciting and will take a long time. This would be really interesting. You think about, we say that vaccine for pancreatic cancer doesn't work. And, you know, in most cases it doesn't. But the vaccines are targeted against the primary tumor with the different tumor microenvironment, stroma and stuff like that. Again, if you think about it through the lens of a surgeon, we don't care about the primary tumor. It's sitting in a bucket. You know, if we can isolate and understand these disseminated tumor cells and understand the antigen makeup and the vulnerabilities, how about a vaccine toward MRD? We haven't been able to do that yet. Then people would be alive with disease, but it would be subclinical and it would be an effective cure. So those are the types of things that we're, you know, trying to push in a lab. One of the difficulties we have is that you would think that you would be able to culture these cells easily, but you can't. So
I think we have plenty of questions. May I request Dr. Srikhand also to come to the dais for discussion? Any questions? You please come and sit there. Everyone wants to cure cancer. I only want to operate.
Hey Chris, thanks again. I mean, I have to really congratulate you because I think this is not to be underestimated. I'm sorry, how many years it took to really set this up, and now that I've seen that you can even probably really have a standardized approach to culturing CDC, this is a breakthrough, I think, and this has really struck me hard because it is something that we've all been thinking of for a long time, and I think this, as you said, this will really make a difference. My question is, would you think that from the signatures that you derive from these cells that you can kind of guide new adjuvant treatment? Is that something where you think you might be able to do that?
yeah, so thank you first of all for your kind words, and that would be wonderful. I'll be honest, we have not yet focused on that just because there's so many questions to answer. You know, we can actually look to some of the data on the primary tumor where they're trying to find molecular signatures toward, you know, at least gemcitabine-based versus FOLFIRINOX-based, and still haven't been successful. You know, it's not that we're waiting for that, but because we're working with so limited cells, it really becomes a numerical and a statistical problem to be able to find it. And so for now, I just don't think it's going to be possible to do. And so it's a very important question, but we're not there yet. And so we've switched from what type of chemo to can we understand the metabolic vulnerabilities, like their dependence on glucose? Can we understand their antigen makeup and try to think of biological targets to target these cells? Now, hopefully somebody will make a breakthrough. So, but great question.
Thank you.
I think both the talks are excellent. For you, Wolfgang, is that CTCs are here to stay. And if you see in the colorectal adjuvant duration, the response, they're already part of the algorithm.
Yep.
I think I really echo your feeling that the surgeon should be part and take the lead. You're in the tumor boards, but you largely leave it to the oncologists. But I think we should be really in the forefront after struggling to do a Whipple and just leave it saying that, okay, you do the rest.
Yeah,
so,
I agree 100%.
Silesh, we do everything, not just the surgery. That's one thing for you.
Dr. Wolfgang, just wanted to ask you, there's been some controversy about resectable pancreatic cancer, if there's a high CA19-9. So there's some, correlation with biology. So do you think CTC will add to that and you will be able to, identify patients who have a normal CA19-9 and a resectable pancreatic cancer, and some of these may benefit from neoadjuvant compared to upfront resection?
That is a wonderful question, and I wish I would have I sort of cut that short. In my last slide, I included some CA19-9 data. So you're absolutely right. So first of all, right now CA19-9 is standard of care. And although it's not standard of care in the United States and at our institution, if somebody has a CA19-9 over 200, even if it's a resectable tumor, we tend to give them neoadjuvant. Now, the CA19-9 predicts pretty good early recurrence, but not perfect. If you add in a composite test, CA19-9, for those who are expressors, circulating cell-free DNA, and CTCs, your AUC curve goes up to the high 0.8. And so each one is important, including CA19-9. But you're absolutely right, and that's going to be the beauty of the test one day. And it's not one person who's going to develop it. As a community, we will develop these biomarkers, we'll put them together in a test, and that first patient that I showed that was anatomically resectable, but not biologically resectable, we'll be able to identify that patient similar to what you said.
Right.
I have a question to Christopher. One of our biggest concerns is which adenocarcinoma is going to respond to neoadjuvant chemotherapy, and the jury is still out. We still don't have accurate response rates. Is there any data which suggests that the swiftness with which circulating tumor cells disappear or turn negative would maybe a prognostic sign that this may be a responder?
Yeah.
And then you could actually pull out, because the big challenge if you use it for resectable tumors is, are we missing a window of opportunity in resection?
You know, that's a great question. I'd never thought of that. And in our study, I wouldn't be able to answer that question because we predetermined during the neoadjuvant that they were going to get blood draws at like 3-week intervals. And so there wasn't enough, there was the rate of drop, we didn't have enough data to know that. But it would be interesting, does the CTC dynamics, so the rate of drop, predict response? And that would be possible. You would have to design a study where in the beginning, after the initiation of neoadjuvant, you would take rapid intervals and look at that. But that's actually a sort of a brilliant idea. So many things to do, and I'd never thought of that. We don't know the answer.
It would have to be quantitative, though.
Yeah, absolutely. It is. So the enumeration, so you can separate the different cell types, but the enumeration is fairly quantitative. And you can even get statistics on it by drawing multiple samples, and you can do, a statistical, looking for statistical differences.
Okay,
That's currently our weakest area in pancreatic cancer. We have a neoadjuvant protocol, but we don't know if the patient is going to respond.
Exactly, right.
Yeah.